Thank you. Good afternoon, everyone. I'm Phillippe Grenier. I'm thoracoabdominal radiologist with a special interest in chest disease. I've been working for many years with Julien Haroche and Zahira Moura. And my department is in charge of evaluating the ECD patients at this hospital, particularly for CT and MR of the body. The thoracoabdominal lesions are in these patients the best modality of imaging. The primary imaging modality is computed tomography. Computed tomography, the new CT scanners permitted to evaluate the entire chest, abdomen, and pelvis in a single 20-second breath hold. So the patient is put in a supine position. The arms is in an upward position to avoid the artifacts. If you put the arms in the body, you have a lot of artifacts. That is not very comfortable. This is necessary to have the good images. Secondly, we have, of course, the perfusion in the vein of the arm to inject contrast material, iodinated contrast material. It is injected in the bolus during the CT acquisition. That permits to enhance the lumen of the vessels, permitting to make the difference between the vessels and the perivascular infiltration, in this disease. And the principle of the acquisition of CT, for those who do not know the principle, we have in the circle here, okay. In the circle here, in the tunnel, you have the tube, and maybe the next one here. And you have the tube and the detectors. And this is rotating very fast. 360-degree rotation in 0.3 seconds. In addition, we see these multi-detector rows, permitting to acquire several slices in one rotation. So now we have in this new generation of CT scanner 128 to 256 rows of detectors, permitting to acquire very rapidly the entire body in a limited number of seconds. And we see here the patient during the CT acquisition when the X-rays are running. The table is moving through the tunnel in a constant speed. So the acquisition is not like this, it's like a helical shape. That's why we call this technique spiral CT or helical CT. And in this way, the images are reconstructed in axial ways, like this. Yeah. And we see, using these parameters, very thin slices, 0.8 millimeter, reconstructed in a small increment, permitting, using these parameters, we have small voxels. The voxel is the analysis, the smallest element of analysis of the density. And the very small voxels having almost cubic dimensions that permits to obtain high resolution in all directions of this. This is axial images, and these are formatted images in a coronal view. And for the chest, for instance, we reconstruct the images in two ways. The first algorithm is a smooth reconstruction algorithm permitting to evaluate the mediastinal. We use the mediastinal window settings permitting to, you see the good contrast between the fat in the wall and the bones. We have the vertebra, the spine, the ribs, and the scapula, and we see the muscle of the chest wall. In the mediastinum, we see the vessels, the aorta. The aorta is very white because they iodinated contrast material in the lumen, and we see the air is black. Air is black in the trachea, and black in the lung. We don't analyze that happening in the lung. But with the second reconstruction using a high resolution reconstruction algorithm, everything is white, except the lung. In the lung, the vessels become visible. We can analyze what is happening in the lung parenchyma. And we see here fine line, this very thin line, thin lines represent the fissures. The fissures represent the expansion of the visceral pleura into the lungs, permitting to separate the different lobes. This is important to understand the abnormalities in lung parenchyma in this disease. Now, first, let's start with the mediastinum. In the mediastinum, the most common pattern of mediastinum infiltration is very vascular infiltration. We see this infiltration of soft tissue around the aorta. And this periaortic infiltration extends from the aortic arch to abdominal aorta. And this is called coated aorta. We see the periaortic sheeting extend upward to the proximal portion of the supraortic trunks, and inferiorly they involve the proximal portion of the intercostal artery, for instance. But in some very severe cases, the infiltration of the mediastinum is very huge, not only around the aorta, but also in all parts of the mediastinum. And we see the diffuse mediastinum infiltration with a narrowing of the superior vena cava and narrowing of the right pulmonary artery, for instance. In this case, we have bilateral pleural thickening and effusions with infiltration of the right atrium wall and the right coronary sulcus. And the bilateral pleural thickening and effusion are all very often associated with mediastinal infiltration and with lung infiltration. You see, make the difference between the fluid in the pleura that doesn't enhance after contrast material and the thickening of the wall of the pleura. The thickening enhanced pleura, visible, separated from the pleural effusion. What about lung parenchyma? But the most common pattern of lung involvement is bilateral smooth thickening of the anterobular septa. This line, perpendicular to the pleura here, are totally abnormal. They represent the thickening of the borders of the lobus that represent the interstitium of the lung, perilobular interstitium of the lung, and we see the thickening of the fissures. But to understand better, I show you the normal appearance of the normal individuals compared with the patient with erdheim-chester disease. And we see these lines perpendicular to the pleura does not exist in a normal individual. In normal individual, the interface between the pleura and the lung parenchyma is free of any abnormal opacity. And these lines, and plus the thickening of the fissures, reflect the lymphangitic distribution of histiocytic infiltration. And this is another case. You see here the thickening of the anterobular septa, thickening of the fissures, and this is a biopsy sample. On the lung biopsy, we see this infiltration of the interstitium along the pleura. And we see the thickening is extending into the interlobular septa here and here. In addition, in this patient, as often, there is associated pleural effusion and thickening of the pleura here, in associated infiltration, local infiltration, focal infiltration of the mediastinum in this patient. More rarely, we have a different pattern. The pattern is made of ground glass opacities. The lung parenchyma appears more gray because there is liquid in the alveoli and interstitium. And we see also very small centrilobular nodular opacity associated with thickening of the fissures. This is due to the accumulation into the alveoli of foamy macrophages of the histocytes. What about abdomen? Well, on the abdomen, the most common pattern, is bilateral and symmetric perirenal infiltration. And this is an example here. This perirenal infiltration is relatively hypoattenuated compared to the cortex of the kidneys. The cortex of the kidneys enhanced at the contrast material and not at all this infiltration. The infiltration is different from the density of the fat. It's a fat, perirenal fat. And associated, of course, we see the sheeting of the abdominal aorta involving the proximal portion of the renal arteries in this case. And on coronal view, we see that this thick perirenal thickening is visible not only in the posterior part, but also in inferior and medial and lateral part. You have some bands extending in the fat of the renal fossa, and this appearance is called hairy appearance. And this also very often associated with the perivascular sheeting. For instance, in this case, you have the distal part of the renal artery that is sheeted by the infiltration, as well the superior mesenteric artery. And sometimes this perirenal infiltration extends to the sinus of the kidney, extending into and expanding the sinus of the kidney, reflecting and leading to a narrowing on obstruction of the ureter. And this is an example with the coronal malformation. We see the pelvocalisectasis due to the obstruction of the proportion of the ureter here, due to the perirenal infiltration is also present as well. And sometimes we have also an extension of perirenal infiltration into adrenal fossae, and surrounding the adrenal glands like here, associated with the left perirenal infiltration extending into the anterior perirenal space. So this is the most common pattern of the abdominal involvement. Of course, the cardiovascular involvement will be presented in more details by the other speakers. It was a great pleasure to present my experience of the thoracoabdominal lesions in erdheim-chester disease. Thank you.
Thank you for your invitation. I have to apologize for my very bad English. And we'll do a short presentation. I will do a short introduction to say that I am a nuclear medicine physician working at La Pitié-Salpêtrière, and I'm involved in follow-up of patients with erdheim-chester disease. I'm going to talk about the role of PET, positron emission tomography, in ECD. Non, c'est la flèche. Marche pas. Ah, ici. Thank you. What is nuclear medicine? Radiopharmaceutical, FDG, fluorodesoxyglucose, is injected after 1 hour of rest, and the examination is performed by scanner, including the PET and CT. The duration is about 15 minutes, and the patient has to be fasting. The images cover the whole body. At left, you can see the CT image, in the middle, the PET image, and the fusion image. Here you can see a volumetric PET image that shows a typical ECD pattern with medullary bone fixation at the legs, on the legs. One application of PET is staging. Here you can see some example in nervous central system with infiltration of spinal cord, pituitary gland, and cerebral venous sinus. Some other example in cervicothoracic area, one retroorbital infiltration here, a maxillary sinus infiltration, and in lung, pleura, and pericardium. In abdominal area, a perirenal fibrosis, an abdominal mass, and a peri-aortic infiltration. Another application of nuclear medicine is a treatment response. First examination on the left is the baseline before treatment. As you can see in the follow-up, on the 3 first months and 1 year later, you can see the progress regression of abnormal signal in bones and mediastinum. Bones and here mediastinum. What is the future? Another example is a pituitary lesion before and after therapy. Pituitary lesion, nothing at the end of the treatment. What is the future? Now we just received a PET-MR system permitting simultaneous acquisition of PET and MRI. And I think it will be used in brain and heart, where heart is not very good. But this is a work in progress. Thank you.
And as you can see on the picture, we are doing cardiac imaging. Under MRI and CT, we are doing interventional radiology with angiography, angioplasty, etc., etc. And we are doing also interventional radiology in cardiovascular, but also in oncology, either in under angiography CT guidance, CT guidance, or MRI guidance. Everything has been explain on the heart, so I will go very fast on the heart, but I can show you some details. And you can see the heart, the scheme of the heart, but there is one anatomic region very important in the heart. It's the right atrioventricular groove. You can see the right coronary artery, and there is some fat around the right coronary artery between the right atrium and the left and the right ventricle. And around the heart, you have the pericardium, which is a bag without any. And with MRI or CT, we can cut the heart in different planes. You have a vertical long axis at the top between the left atrium and the left ventricle, and you can see the kinetic of the ventricle. You have the horizontal long axis with a 4-chamber view. You have the right atrium, the left atrium, the right ventricle, and the left ventricle. And there is a very important region that you have to see. It's here. It's just around the right coronary artery between the right atrium and the right ventricle, and also the wall of the right atrium. And you have the final short axis plane between, you can see both ventricle, right ventricle and left ventricle. And the main one of the most frequent lesions in erdheim-chester is the fluid in the pericardium, and you can see on the right around the heart. The heart is in the pericardium with a lot of fluid. And for this patient, you can look at the right coronary artery between the right atrium and the right ventricle, and you can see the right coronary artery, and there is some infiltration around the right coronary artery. It's one of the main lesions in erdheim-chester. And for some patients, you can see the infiltration of the right coronary artery around the right coronary artery. You can see the fluid in the pericardium, and also you can see very thickening of the right atrium, the wall of the right atrium. And for this patient. And you can see on this patient the infiltration around the right coronary artery, and also in the mediastinum around the aorta, and also in the posterior wall of the right atrium and in the septum, a very thick septum between two atria. But the treatment sometimes, very often, you can look at the decrease of the infiltration between the right coronary artery. You can see the posterior wall of the right atrium, the thickening is decreasing, and also the fluid in the pericardium is totally disappeared. And this is the last slide, but you can see after 3 months of treatment, all the lesions had disappeared. The posterior wall of the right atrium is quite normal at 3 months, and the infiltration between the right coronary has disappeared. So thank you for your attention.